So today's session invites pharmacy students, technicians, and pharmacists to think a bit differently about the regulatory structures that shape how we practice. And it is my pleasure to introduce our speaker, Tim Frost. Tim is a senior fellow at Cicero, where he focuses on healthcare regulatory reform and workforce policy. He brings a wealth of experience in both government and healthcare, previously serving as the chief of staff to the Idaho Attorney General and as deputy administrator of Idaho's Division of Occupational and Professional Licenses. Tim's insights have been published in respective pharmacy academic journals, and his drive to improve systems and achieve measurable outcomes is evident in everything that he does. He holds degrees in pharmaceutical sciences and pharmacy, and he brings a unique perspective shaped by his rural upbringing on a family farm in Michigan. Outside of policy and research, Tim is a dedicated husband, proud father, and enjoys the outdoors with his yellow lab and duck hunting partner. So please join me in welcoming Tim Frost to the stage.
Thanks. Do a little bit of testing on this. A little loud. We good? We'll work right there. Well, welcome and good morning. Appreciate the opportunity to be here in Milwaukee and the opportunity to present here today. Super excited to be here. Maybe we'll just step away from this podium for a minute. Super excited to be here. As he highlighted, I am a Michigander. I grew up in Southeast Michigan, just about 40 minutes south of, we'll get there. 40 minutes south of Ann Arbor, just north of Toledo, Ohio. So spent many of summers in the Upper Peninsula in the Hiawatha National Forest. And so I've got family in Wisconsin as well. So, you know, for me, this is a little bit of coming home while living in the West in Boise, Idaho. A few relevant financial relationships. We might have to just go solo on this. They're working on that. Okay. Relevant financial relationships to get started. For this, I have disclosed I'm president and active consultant for my firm, 50 Elixir. We work with a number of different healthcare companies across the different pharmacy sectors. I'm also a senior fellow with the Cicero Institute. We are a 501c3 nonprofit think tank that works on many different reforms, including healthcare reforms, regulatory reform, homelessness policy. I don't have any relevant financial relationships to disclose. I don't think I can say this for ACPE, but I'm open to those relationships after this. From a learning objective perspective, we're going to, hopefully by the end of this, we'll be able to define full practice authority as it relates to independent pharmacy services, be able to define standard of care. What does that mean from a regulatory standpoint? And what does that mean as it relates to our future as pharmacists and pharmacy technicians? Summarize critical steps to implement a standard of care model in pharmacy practice, as well as discuss the impact of standard of care on patient access and health outcomes. So let's dive in. What's the background? Well, we have a reality across the United States, in the state of Wisconsin, that more than 30% of patients do not have a primary care provider. So it's not just we have a shortage of physicians looming in every state. We have patients right now that don't have access to their primary care provider. With that being said, we have pharmacies that 90% of patients live within 5 miles of a community pharmacy. And many of those pharmacies in an urban area are even closer, within a 2-mile distance. And so we have the most accessible healthcare provider, over 300,000 pharmacists across the nation that for the most part are untapped. We have the ability, but we're not tapping into that ability. Pharmacists are poised to solve primary care issues. We're poised to diagnose and manage chronic care conditions. We're poised to be able to test and treat and handle minor ailments in a patient walk-ins. We can take a step into that role and handle that 30% of patients who do not have a primary care provider, and the many of other patients who are looking to transition from their current PCP. In order to do this, I think it's important to remind ourselves of pharmacist education and training. We have standardized education and training across the country. We have standardized ACPE accreditation. This includes 4 years of postdoctorate education. That's 1,740 hours of clinical patient training. That is more than double that of APRNs who go through the clinical patient hours of training. And so when you look at scope of practice and you talk about standard of care and you talk about where the state of the country is from a primary care perspective, you have APRNs that more than 35 states have ascended to full practice authority. And you have pharmacists that are doctorate trained and have twice the amount of patient clinical hours of APRNs. It's a problem that we need to solve. It's a serious issue that we have an untapped scenario. I think it's important to highlight the pharmacist patient care process that happened in 2014 from the Joint Commission of Pharmacy Practitioners. It highlighted the various different frameworks of collecting subjective and objective patient evidence, assessing that information, developing a care plan, implementing that care plan, and having a follow-up process with the patient. This was a formalization, what I view has been in ACPE standards for a long time. How many in the room at some point in your pharmacy education, regardless of your background, had some form of SOAP note training from your education? I think I see everybody's hand in the room. In other words, collecting subjective and objective patient evidence, thinking through what the care plan should be, thinking through what's best for the patient, and having some form of follow-up process is what pharmacists do in every single setting, every single day, and have done so for 30 years. So this is just a codification of that. ACPE took that in the 2016 standards and codified it into the standards to make it very clear. This is what we've been doing for a long, long time. And I'm pretty proud of our nation's, our leaders in ACPE to start being clear about this is where we stand, this is where our education is, and not back down from that at all, regardless of what other healthcare providers have been saying. I think what's even more interesting is in the 2025 standards, pivoting from 2016 to 2025, for years, pharmacy, for the most part, we've kind of avoided some of the terminology conflicts. We avoided the diagnostic word. We've avoided the prescribing word. We try to stay away from that in worry or concern of how other providers are going to feel. Our 2025 ACPE standards, they get to the heart of it. They talk about diagnosis in the standards. They talk about prescribing in the standards. They talk about ordering, administering, and interpreting laboratory tests. They talk about drug administration. And so we're finally at this pivoting point where, as a profession, I think we've started to align, hey, this is where our education has been for a long, long time. We've had a standardized doctorate education since the early 2000s in every college around the country. We have consistent ACPE standards that we're being clear about our terminology of this is how we're training our individuals. And now we have to think through, well, what does that mean from a legal perspective? What does that mean from a law perspective? How do pharmacists ascend into that type of role? I like the quote that comes from Alex Adams and Crystal Weaver that says, for pharmacists to fully engage in the patient care process, state laws must enable full participation. By unleashing pharmacists to fully engage in the process, patient care delivery and outcomes can be improved and total healthcare cost can be reduced. So why can't we today? Why is it that pharmacists can't step up into that role and fill that gap that 30% of patients don't have a primary care provider? Why can't pharmacists step into that gap when patients are experiencing a burnt out primary care provider? Why can't they pivot to their pharmacy and local? The reality is clinical services are overrated right now. We have regulatory strings across the country preventing pharmacists from practicing at the top of their education, training, and experience. We have that standardized ACP education. It's been in place for decades, but the law doesn't reflect that clinical education, training, and experience. So what does that mean from just from a picture perspective? I like to look at it as the law is a ceiling for each of us as providers. in a bright line regulation ontology of the law, you have a minimum entry barrier, which we all have as a doctorate education. You have to have a pharmacist license. You have to pass your NAPLEX. In most states, not all, you have to pass an MPJE. That's your minimum. But what is your ability to perform something and provide care to patients? You have a legal ceiling. Excuse me. And with that legal ceiling, in many states, if you're not under a standard of care model, that is a snap line across every single healthcare provider. Well, we know that providing care is dynamic. Each pharmacist has a little bit different of experiences. They have a little bit different of a knowledge as it relates to their background, the unique patient care populations that they provided. Some have done residency, some haven't done residency. Some have been in the profession for 30 years and have clinical knowledge that, I'll never gain in my time as a pharmacist. In other words, there's some heterogeneity in that, like clinical education and training it's dynamic based on the practitioner. But if the law is static, that means practitioner A might be perfect. Practitioner B, that ceiling might be too low for practitioner B. Practitioner C, I don't know, maybe practitioner C shouldn't be able to practice at the top of what the law allows. So how do you create a regulatory structure that captures that flexibility between all three providers? And this is where standard of care comes into the place. It creates a framing that your scope of practice and what you're allowed to do is connected to your individual education, training, and experience. Would a reasonable and prudent pharmacist in a similar situation or setting with your background provide that education? What it does, it allows the law to flex up based off of your particular education as a pharmacist. So we'll start. It's early. I don't want to talk the complete time. So take this as a time to think, pair, and share at your group. Talk about if pharmacists had full practice authority, if there were no barriers from a legal perspective, what patient care service would you provide to your community? What high impact service would you dream about providing your community? What gap in your community exists today? What thing interests you from the perspective of providing care that you would do tomorrow if there were no barriers in place? Let's use a few minutes, talk at your table, we'll think, pair, share, and then we'll go from there. I see a few tables wrapping up. I see a few people I gave really good cover to go get a muffin and coffee as well, which that's okay. There's always one in every crowd, but I'd love to hear, we've got 2 microphones up front. If anybody in the room would be willing to share, what do they envision the future of looking at? What would be the service that they would provide in your community? I'd love for a few people to share. And yes, it'll get really awkward if we don't have people that are willing to step up. But I'd love to hear from them. What would it be for your community?
My name is Rachel Schomburg, and I would immediately expand our ability to adjust asthma and COPD therapies. If I see that you fill your albuterol every month, I know you need something different in your controller medicine, and I can do that.
I love it. Thank you so much. Let's give her a hand. Who else is willing to share? What would you provide in your community? What immediately came to mind in the conversation?
Hi, good morning. Thanks for the question. My name is Mike Brown from Concordia University. I would absolutely bring mental health practice with pharmacists out in the community to the fore. I think there's great opportunities to make a difference. Society desperately needs more mental health providers, and our ability as pharmacists and our training would certainly allow us to do that very well. Thank you.
I love it. Thank you, Mike.
Good morning, Haneti Bagwa. I'm board director of pharmacy, Reedsburg Area Medical Center. I would have the pharmacists more involved in de-prescribing.
Awesome.
Good morning. My name is Stefan Noonan, POI1 at Medical College of Wisconsin. Working with the veterans, I see a lot of issues with chronic or acute infections that lead to further complications. As pharmacists are consulted regularly in ID, I feel like preventing multiple drug-resistant organisms in the community setting and having consultations and or early interventions in the community might prevent further complications that lead to either hospitalizations, which is leading to a lot of what we see in the hospitals, such as MRSA, C. diff, and other issues. So stopping at the community level before it has to escalate and causing this MMRO issue that we see nowadays would be an excellent source for pharmacists to intervene at.
Love it. Fantastic. Thank you. Anybody else who'd like to share? This is your last opportunity for the mic. We'll keep rolling here. I think you heard in that, and before we jump forward, I think it's important to highlight, we heard new authority as in the ability to initiate and provide therapy. We also heard preventative of just, maybe I won't actually use a specific authority, I just want to be recognized in a way that allows me to integrate better as a collaborator. And we also heard de-prescribing. I would like to use my authority to initiate to also de-initiate therapy as well. And I think that's important because as providers, we can talk through the history of Wisconsin, for example, which has a fantastic history of collaborative practice agreements. 20, 30 years worth of history and a strong uptake. And so there has been integration. Wisconsin has been a leader and a forefront on this, but it begs a really good question. What does the future look like forward? Because collaborative care is dependent on somebody delegating that to you. And something that can be delegated can be undelegated at any time. So there's an important piece of this conversation of moving to full practice authority, moving to an independent care doesn't mean that all of a sudden pharmacist adds all kinds of new therapies to patients. What it means is you're seen as an independent provider. Your authority is connected to the law as an independent provider. And you might use that to add therapy. You might use that to remove therapy. You might use that to optimize current therapy. But you need that broad framework for you to do what's best for your patient. So what are the policy prescriptions for bridging that clinical services gap? That gap that we talked about earlier in a bright line regulation framing where if you snap a line across, practitioner A, B, and C are different, but the law says one thing. How do you bridge that gap of getting there to a standard of care framework that accounts for the education and training of practitioner A, B, and C? I think there's two policy prescriptions that states can approach on this. One is adopt standard of care, and two is adopt full practice authority. So what does that mean? We'll jump into that. First, we have to define what standard of care is. The term standard of care in a medical context refers to a healthcare practitioner acting within their education, training, and experience. It's a regulatory benchmark that a regulatory board would use to determine, did this individual provide care that a reasonable and prudent pharmacist in a similar situation or setting would provide? It's a comparator framework rather than it is one singular thing of like, you may do this, you may not do this. And it allows for that flexibility between what you're actually providing. If a physician, a pharmacist, a nurse practitioner, a PA, an optometrist, we could go down the long list, fails to provide the standard of care and practice, that would allow the licensing board and then the courts to determine this is cause for discipline, there's cause for negligent practice, and it would allow them to pursue potential administrative discipline on that licensee. So it's a regulatory framework that allows for that flexibility on the scope of practice side, but it allows for that strong accountability measures on the back end as it relates to patient safety. So what are the benefits? Why have a standard of care regulatory model rather than a bright line framework? If we think about this, I think we need to think of the history of many other professions as well and how that's transitioned. Practice of medicine and the practice of nursing pivoted to standard of care back in the 60s to 80s, depending on the state. And you're like, well, what do you mean by that? There's a broad definition of what the practice of medicine is determined. And most of the time, physicians don't have to go back to the legislature for any new technology advancements, any new services they want to provide, any new novel drugs that come out. That doesn't require a law change. And you're like, well, why? Because they've adopted a standard of care regulatory framework. It's not a top-down approach of you only may do this, and therefore you have to ask permission from the legislature or the board for every new service or every new technology. What it is, it's automatically allowed with the exception of if it's prohibited, as long as it's in your education, training, and experience. And so as technology has evolved, as clinical guidelines has evolved, as modern medicine has evolved, the way the practice acts for medicine and nursing have been set up allows for that flexibility for them to grow over time. They can go get a new educational update on a particular new technology or a particular new surgery. It doesn't specify all the level of what we would normally see in pharmacy. And so we had a little bit of a divergence early on from our profession versus those other professions. And I think that's one of the critical pieces that we're really considering in a standard of care scenario is should pharmacy move towards a standard of care model? And as pharmacists are decentralizing from the dispensing process and pivoting more towards a patient services process, would a standard of care regulatory framework be a better model for pharmacists to work under rather than having the historical model of a bright line regulation? So what does this mean from a law perspective? This is legal jargon, but simply what it says from a standard of care language is determine whether or not specific scope of practice in your state is to be delegated or whether or not you can independently provide it. First, you'll determine, is this expressly prohibited by federal law or rule? Is this expressly prohibited by state law or rule? And does this fall within the education, training, and experience of the individual providing the service? So it flips that script. It doesn't mean that there will be nothing prohibited in the state of Wisconsin. What it simply means is you have clarity on what's prohibited, but the rest of it is open. The rest of it is open and allows flexibility for you to determine then, hey, I might not have to go do a significant amount of training to pick up this knowledge base. I already have this. I was taught this in college. Or you know what? I'm not real comfortable with providing that new service, but if I did a couple hours of CE on it, I would feel very comfortable and I would be able to defend that I have the education, training, and experience. Or, I think I probably need to do some type of formalized, certification process for me to perform this and defend that I'm doing this. But in all those scenarios, you don't have to go back to the law to change it for you to perform that. You as an individual can determine whether or not you want to add on that training to yourself and have the ability to then say, like, I feel comfortable and a reasonable and prudent pharmacist in a similar situation would have a similar framework of education that I would have, and they would make that similar decision making. So we talked about standard of care and what that means. That's a regulatory framework by which a regulatory board and the courts would consider, does your decision-making fall within your scope of practice? But what is full practice authority? At the core of achieving full practice authority, it's the underpinnings of independent authority, not a delegated framework. It's independent authority based on evidence-based practice, unhindered by the outdated legislative and regulatory restrictions. I'm a big fan of Dr. Ross Suzuki at the University of Alberta. Alberta as a province in Canada is probably, the model and the standard of what we can do as a country from a state perspective on pharmacist prescribing. early 2006, they pivoted to an incredibly broad prescribing framework. And so they've got 20 years on the books and a lot of randomized controlled trials showing that pharmacists in a community, in a hospital, in a almost every setting, statistically significant outperform primary care providers, whether that be physicians or APRNs. Incredible amount of studies that are published in solid peer-reviewed journals on this. And one of the quotes he has is, full scope pharmacist service include all proactive and comprehensive interventions that prevent or manage illness and are within an individual's competency to perform independently. And the reason why I like that quote is he doesn't define a list. He doesn't define a list of drug categories. He doesn't define a list of disease states. He connects it back to the pharmacist's education and training. So I think, important part of this transition that states are talking about, it's no longer a conversation of we should expand practice or we should enhance our services or expand the scope of practice. At the end of the day, I just want full practice authority as a pharmacist. I want to be able to practice at the top of my education, training, and experience. And so that's where the terminology of full practice authority comes from. And it comes from a similar success framework that APRNs utilized in the early 2000s when they pivoted from collaborative practice agreement to full practice authority as well. So on full practice authority, what does that mean from a legal standpoint? What would need to be done within your State Practice Act? You would have to open up your practice of pharmacy definition. There are many ways to do this. We could talk through the 15 different words you could use to make this work. But in short, it usually includes clarity on diagnosis, the words diagnosis, the words prescribing. There's been a few states that have tackled it with a broad framework. In other words, allowing the prescribing of drugs, drug categories that do not require new diagnosis, are guided by the results of CLIA wave test in a patient emergency, and are minor or generally self-limiting. If you were to use a broad framework like that, that opens up the prescribing for probably 500 or so drug categories, effectively getting you to a full practice authority framework and effectively allowing you to diagnose most of the things that would fall naturally within pharmacist education and training. So how do we pull this all together? I'm a big fan of Venn diagrams. Some people hate Venn diagrams, and for that, I'm sorry, you'll have to get over it. But what I like the center up standard of care. And what does this mean in the broader piece of what we're talking about? Pharmacists want to achieve full practice authority. We also want to solve primary care issues and access issues and drug therapy issues for our patients. We also, at the same time, want to prevent overregulation. In order for us to really perform at the top of our education, training, and experience, we have to solve these issues with the legislature. We have to solve them with the Board of Pharmacy to prevent that overregulation. On the same side, I know pharmacists want safe patient care. I know pharmacists recognize that the drug supply chain and providing this type of care has high risk to patients. And so they do want strong accountability measures in the back end. They don't want this to be a utopia for bad care to be created. And so standard of care creates that entire framework. It creates that maximum practice on the top end to your education, training, experience, but it also has strong accountability measures on the back end as well. Standard of care has been in place for almost 40 years to where the law, tort law, attorney general's offices, they've litigated based off of standard of care for a long time. They just haven't done so in the pharmacy profession because our pharmacy profession has been very bright line. I like to say, and thankfully Wisconsin's laws and rules are nowhere near as long, but I love making fun of California because I live in Idaho. And California has 850 pages of statute and rules. For you to be compliant in California, you essentially have to memorize a Harry Potter novel. All right? And you think through, how do we navigate professional autonomy? How do we prevent burnout? If you are thinking every single day of compliance of a novel that large, of course you're going to be burnout. Of course you're going to be frustrated. Of course you're not going to be thinking about the best possible outcome of the patient because you're thinking about compliance rather than thinking what's best for our patients. And I think as pharmacists, we need to really think through how do we solve that? There's been a lot of conversations over the last 5 years of how do we think through the future of our profession, that people want to be in the profession, want to join the profession, want to stay in the profession. And I think standard of care connects very, very closely with pharmacists' health and well-being when it comes to them being able to practice. Because if you can't practice to the top of your education and training and experience, you are going to be naturally frustrated. If you are over-regulated to the point that all you're thinking about is compliance, that is naturally going to be a burden that you are thinking about, and that's not healthy for your patients either. That is not the best possible outcome. And the best possible outcome cannot occur if we continue to regulate to the lowest common denominator. We need the ability to go after the lowest common denominator in our profession. We need the ability to essentially excise the individuals that practice to the bottom of the barrel. But we don't want to regulate everybody else at that level. We need the best of the best to be able to practice at the top of their education, training, and experience. So what does it look like today? Full practice authority. We've had 3 states have adopted explicit standard of care language. Idaho has adopted it, Iowa has adopted it, and Alaska has adopted it. And then we have 4 states that have adopted a very broad full practice authority allowance for pharmacists to prescribe. In Idaho, it specifically says prescribing. In Iowa, it says you can issue a prescription. In Colorado and in Montana, it creates the model that pharmacists can prescribe drugs and devices that do not require a new diagnosis, are guided by the results of a CLIA wave test, are minor and generally self-limiting, or for patient emergencies. So they took a little bit different approach. They've accomplished the full practice authority piece of the policy. They haven't quite yet adopted the explicit standard of care provision. And so we've got a list of some early adopter states, but there's an incredible amount of states that are trying to think through what is the next steps for our future? What does our vision look like as an association for the next 5 years? What are the things that we prioritize, and what is our pathway towards full practice authority and standard of care? So what does it look like after these states have adopted standard of care? In Idaho in 2017 and 2024, adopting explicit standard of care meant that the Board of Pharmacy needed to go and do a rule rewrite after the legislature made their changes. In other words, you can fix the legal provisions in the statute, but the Board of Pharmacy then has to thoughtfully think through, how do we pivot our mental framework and move to standard of care? So what are the things that we need to remove in our rule book that are too specific, that are too bright line, that are regulating pharmacists to the lowest common denominator? Alaska did a similar thing in 2023. They did a really strong spring cleaning of rules that expanded pharmacists' scope of practice, allowed continuation of therapy, removed the NPJE, a significant overhaul. Iowa just finished this. Rules went effective, I think, beginning of this week, and cut about 50% of their rule book as well, in a framing of when they moved to standard of care, they had to think through, what do we keep? What do we not keep? And so a part of this is, if Wisconsin goes down this road to adopt an explicit standard of care model and full practice authority, there will be a need to work with your Board of Pharmacy after you get legislative changes to implement those legislative changes. You can have a great practice act and the legislature can be completely behind pharmacists, but then your Board of Pharmacy can completely drop the ball and adopt a significant amount of restrictions that prevent you from practicing at the top of your education, training, experience. We saw this in Utah. Utah had a really solid practice act, and the Board of Pharmacy has absolutely ruined it from a rulemaking perspective. And so that's part of the future here, is the dynamics between a legislative change as well as the follow-through from a profession with your regulatory board. So if we were to look at this, though, from a state perspective, I want to give an actual example of, like, what do you mean when you say being specific versus not specific? If we were to look at just vaccines, the ability to prescribe and administer a vaccine. If we were to look at Indiana, it talks about administrations of immunizations. It requires a physician standing order. It details how that order has to be provided. It lists the specific vaccines, training, age restrictions. very bright line, very specific, specific to only immunizations as well. If you were to look at Alaska, it says a pharmacist may independently prescribe and administer a vaccine and related emergency medications, but then it specifies training requirements for pharmacists as it relates to prescribing and administering vaccines. It includes Baird's information. So you see the comparator of Indiana is incredibly specific and very narrow. It's also a dependent authority on a standing order. If you look at Alaska, it moves an independent authority, but it's still specific to immunizations. If you were to look at Idaho, you would see in the practice of pharmacy definition the term administration, the ability to administer a drug, and you would see the word prescribing of drugs and devices. In other words, it doesn't say immunization. There's nowhere in Idaho's statute or rules that specify anything on vaccines and immunizations. In other words, your authority for you to provide full practice and go into all these different various disease states doesn't mean that you need to list categories for every single one of those disease states. It doesn't mean that you have to have a specific mandatory educational program for every new drug category or device. When we look at the practice of nursing and look at the practice of medicine, what we will find is they rely on their standardized education and training and that doctorate program as the core basis for them being able to practice under a standard of care model. So what does that mean when we're talking independent prescribing? That means if you go down this road, don't adopt advanced practice designations from a licensure perspective. Don't connect everything to a collaborative practice agreement. Don't require mandatory liability and mandatory CE on every new drug and device. These are scenarios that as states have went down this road, they've got caught in the weeds of that. They've picked a singular category, and then you look at that and you're like, how did we land on a 40-page HIV PEP and PrEP protocol in the state of Maine? The legislature made it pretty simple, but the Board of Pharmacy landed in an incredibly specific way. And I think that's the challenge. I think as pharmacists, we're very type A, we're very specific. I want to know where I need to be, when I need to be. I need to tell me what to do, what to not do, what's okay, what's not okay. And this is going to be challenging for us because if the legislature gives you the flexibility to say, go take care of your patients, and the Board of Pharmacy says, go take care of your patients, that means you can't call the Board of Pharmacy every 2 days. Am I allowed to do this? I would like to provide this service. Is it legal to do X, Y, and Z? Transitioning to a standard of care framework, it changes our thinking into would a reasonable and prudent pharmacist perform this service? Am I personally educated and trained to perform this service? Would it be reasonable for me to perform this service? That's not as black and white. And there's a little bit of uncomfortability that we're going to have at times. And so some pharmacists are going to immediately jump into that because that's their personality. And some pharmacists are going to be like, you know what, I'm going to watch this for a few years. Like, we'll see how this plays out. And then I'll determine if I'm going to pick that up. And the same goes on laboratory tests. The same goes on drug administration. When we approach lab testing and drug administration, those are supplemental to independent prescribing. There are times that in order to properly initiate therapy, you need clear authority to order, interpret, and administer a laboratory test. Preferably, you don't limit it to CLIA waived authority. There are many non-CLIA waived tests that are wave testing, non-wave testing at a moderate level or high complexity lab tests that pharmacists can and should be ordering, interpreting, and administering. So from a law perspective, you just need clarity under the law to order, interpret, and administer laboratory tests. You don't need to go into the weeds of limiting to CLIA waived. You don't need to go into the weeds of listing a long list of here are the tests that you may order. You need a full practice authority framework for testing. The same goes for drug administration. You don't need a list of drugs that a pharmacist may administer. You need the framework for broad drug administration, whether it be controlled or not controlled, because we know pharmacists also administer medication-assisted therapy for substance use disorder. So kind of recap a little bit, what does this look like in a state level? These things can be reordered depending on what your approach is, but you have to adopt a broad practice of pharmacy definition. for full practice authority. That is an update that will have to occur. You have to allow elasticity of scope of practice advancement over time. You need that standard of care explicit language. That way, when you have new technology, new drugs brought to the market, new innovation brought to the market, you don't need to go back to the law for that change. You have the flexibility to step into that role. You're going to have to work as a profession with your board of pharmacy to determine what instances you still want prescriptive regulation. There are going to be some things as a state you decide, you know what, we're not going to go completely silent on that topic. A lot of times states have specific nuances for controlled substances or for compounding or for whatever there are state nuances. States are the laboratories of democracy, and Wisconsin can be different. You go into every state and you're like, we're different. You're like, not really, but you have your own law book and your own rule book, so you can be different. You can say you're different. And that's where that comes in. There are scenarios that your board of pharmacy and as PSW advocates with the board of pharmacy that you might decide, you know what, Iowa might have decided to be silent on this, but we shouldn't be in Wisconsin. And here's why. And that's okay. But you deviate the rest of the laws and rules under a standard of care framework. Eliminate the rest of unnecessary regulations, and then ensure that we're advocating to strengthen accountability measures on the back end. We also want to give the tools to our board of pharmacy, to our attorney general's offices, to navigate back end complaints to be able to handle the bad actor situations under standard of care. So what does this look like? What are some bold opportunities? This is just a list of examples of how you could approach it. I think this is something that, you know, PSW and your leader and board of directors are going to work on and decide what's best. But some approaches I've seen in the States, you could combine standard of care and updating your pharmacy practice definition together and send that as a package. That way, when you're talking about initiating and diagnosing and prescribing, and they want to add in all these restrictions on this and all these protocols, you can defer to, well, we have an explicit standard of care provision. We don't need to add all those things because it's operating under standard of care. And you're able to utilize that in your advocacy. Some states, the pathway is utilizing omnibus bills. We saw that with the federal government with a big, beautiful bill. Like some states and the federal government sometimes use omnibus as the package to get things done. There are times where it's good to utilize Board of Pharmacy sunset clauses. Most states have some form of regulatory sunset already codified within your Administrative Procedures Act. And that's a great opportunity to work with your Board of Pharmacy for some new innovation. New governor executive orders, whether it be red tape reduction, whether that be licensure reciprocity reform. Governors are interested in removing red tape from the perspective of bringing new providers into the state for new competition, for access to care. Those are opportunities that you can work with your governor, regardless of the side of the aisle of the current politics in the state, to think through what are the pathways that we can spur some innovation. Sometimes they can be multi-healthcare profession statutory updates. Sometimes you can look at your statutes as a whole. Maybe different sections need to be cleaned up. Sometimes states will have definition sections in 20 different areas of statute. And you could do a definition consolidation bill that adds clarity to the law, to makes it easier to read from a law perspective. Sometimes that's the best way to navigate it. Prescriber dispensing with pharmacist prescribing, remove the conflict of interest. I don't know where Wisconsin law is on prescriber dispensing, but I've seen that work in states as well as a part of that conversation. I'd also say there's a lot of think tanks that are interested in pharmacist prescribing right now. And there's a lot of publications out there that I think most people aren't aware of. In the last 5 years, particularly at the beginning of COVID, a lot of entities are starting to talk about pharmacist full practice authority, are starting to talk about how do we move the ball down the field as it relates to the barriers of innovation and the barriers of competition on primary care access. We do know we're going to get some medical opposition arguments, but I wouldn't get caught on that. Every state's a little bit different on this. Some states have a great working relationship with their medical association. And that might be the scenario in Wisconsin in the path forward of it's a great negotiation, it's a great collaboration. It might not. What I can say is there will be some level of opposition no matter what. You will have some physicians in the state that are just uncomfortable with it. And so here are the arguments that you'll hear in every state. And you're like, what do you mean by every state? There's a good publication that was in the early 1980s talking about, there's a pharmacist that published on what were the opposition to expanding collaborative practice agreements around the country in the 1980s. And the framework was every one of these things. Pharmacists do not have the education and training compared to that of physicians. This will create fragmentation of the patient-centered medical home model. The only safe access includes physician supervision and requirements over pharmacists. That the only way that we can do this is through collaborative practice agreements. Increase access to care, increase access to poor quality and unsafe care, advocating unsafe care is far worse than no patient care. I'll argue that one all day long, but creates liability insurance issues, focusing on recent state and national pharmacy reports of pharmacist workforce and burnout in workforce. There will be some level of utilization in this. We see this from the American Medical Association. We see them send in comment letters on state legislation. We know this is the common piece of what, so we have to be ready to talk about pharmacist education and our standardized curriculum. We have to be able to talk about how long it's been standardized and that pharmacists are practice ready today. We have to be able to talk about how pharmacists don't add to fragmentation of patient care. We have to be able to talk about that 30% of patients don't even have a primary care provider. And so you're not fragmenting care if you're providing new access to at least 30% of them. And then we can talk about how we already interprofessionally work with other healthcare providers and connect them and are an important venue piece and a triage piece to care. We can talk about that if you only have collaborative practice agreements, that means that can be undelegated at any time, and that can rip access away from patients. And so the gold standard can't be collaborative practice agreements long-term, because if you have collaborative practice agreements in place and you have a supervising physician that pulls the rug from out under that, that creates a fragmentation of the patient care model, the patient-centered medical home model. That creates the very problem that the opposition is saying you're going to create if you move to independent authority. We know for a fact in working with Pharmacists Mutual that this does not create liability concerns, and liability insurance has not increased in the states that have implemented full practice authority and standard of care. And we also know that no access to care is no access to care. It's not increased access to unsafe care. We have patients that are legitimately walking into places that are a way higher level of triage care, some of which are getting turned away because of the sheer amount of that particular venue. And not only could we provide access to that, we could also take that and put that in a much better venue. We can create preventative health solutions before it ever turns into an urgent care visit or emergency room visit. We've had some incredible stories from around the country of what that could look like and what that has looked like after it's been implemented. It's important to coalition build, and this starts with you as a pharmacist. It starts with, in your community, what can you do to provide a better level of advocacy? What we find is across the country, insurers are supportive of pharmacists as independent authority. Even hospital associations, in most instances, if you go work with them and talk with them ahead of time, hospital associations are very supportive of pharmacists in this role because they've been utilizing pharmacists at this high level of capacity for decades. AARP is a strong supporter of pharmacist prescribing. The Farm Bureau, if they have their own insurance program in the state, is a supporter of pharmacist prescribing. Colleges of pharmacy, you need to be at the table. Our deans and assistant deans, you need to be at the table. We cannot get this done in a state if the colleges of pharmacy aren't very clear when they go have conversations with legislators and with the boards of pharmacy that this is what we've been training pharmacists to do for the last 30 and 40 years. It's incredibly important for your voice to be at the table to provide a sense of stability that these individuals are practice ready. And then to the extent that you feel like there are some pharmacists that might not be ready, we'll get them ready. We'll get them ready through engaging them with the State Pharmacy Association. We'll get them ready by having additional CE programs on critical access type issues. In other words, there's some level of once you move to standard of care and full practice authority that everybody has to come to the table and say, all right, how do we transition into this? And it's been really fun to see the state of Iowa have done it better than even Idaho has done it, of bringing the profession along, having those standard of care symposiums, having those trainings, having those community specific things that would be helpful. I think it's awesome to bring patient advocacy groups and coalitions to the table. If there's specific ones in Wisconsin that have a strong presence, that could be where you engage. Chambers of commerce in your local community. I've seen multiple chambers of commerce support pharmacist prescribing, and that's going to come from you as a pharmacist or pharmacy technician talking with the people local to your community, engaging and say, what if we could bring 2 new pharmacies to our community? You're like, well, what's preventing them? And you can talk through the nuances of what's going on in the drug supply chain and the reimbursement marketplace. And you can also talk about what it would be if pharmacists could practice at the top of their education and training. The things we talked about, what we envision, you can bring that as a business to your community. And chambers of commerce will absolutely buy into that and have an interest in that. And then I think there are physician champions. Not every physician is our enemy in this. Some are, and I've had plenty of the battles when it comes to those legislative fights. But you'd be surprised. There are a lot of physicians that will come to the table and advocate for pharmacists saying, I've been utilizing them in this capacity. I cannot work without my pharmacist. I cannot live without my pharmacist. I cannot function without my pharmacist. And if you have those relationships, you need to tap into those relationships and bring those physicians to the table to be part of that conversation. We did a polling at the Cicero Institute that highlighted 60% of voters support increasing affordable urgent care access by allowing pharmacists to practice to the full scope of their education and training. Good split between Democrats, Republicans, and independents, a good split between the age requirements, good split between gender. I think we would be surprised how much patients want to see this. Our country wants to see this. And so that's part of the conversation as we talk with legislators and policymakers. And I'll kind of finish on, when you're talking about standard of care, you've been talking about the reality of being silent in some issues. And what does that actually mean? Like, how has that been implemented? A few things I think are important. There are always external market forces at play within our profession. One is just consumer acceptance and demand. We did polling that highlighted patients want to see this, but the question is that growing? What we're seeing in states is there's uptake. Is it a drove of everybody's going to their pharmacy overnight for the service? No, but that continues to increase. We saw that with vaccinations after H1N1 in the late 2009, 2010, 2011. We saw the massive change of patient acceptance and demand towards immunizations and going to their community pharmacy for that. We saw that during COVID with laboratory testing and test and treat. And we'll continue to see that if you adopt a standard of care allowance. From a state policy, a payer perspective, Idaho Medicaid fully enrolls pharmacists as ordering and rendering providers in all settings. You sign up and get credentialed, and you have the full ability for reimbursement at the same level of an APRN, so 85% of the physician rates. Private payers took about 2 years for the private payers, but all private payers in Idaho are completely on board as it relates to credentialing pharmacists as ordering and rendering providers. That includes Blue Cross, Regents, Select Health, Intermountain, et cetera. And so while they were slower than Medicaid, we didn't have a mandate to require payment for services. And so oftentimes when we have this conversation, provider status, some states go the approach of including a mandatory payment for services when they tackle that scope of practice. That might be the right approach for Wisconsin. Some states don't. In Idaho, our state was not to include mandatory payment. But what I think is interesting is the payers followed it. The payers within a 2-year period had an uptake to allow pharmacists to get credentialed and privileged for it. We did use some COVID grants to try to assist in some of the credentialing and privileging. There were a few pharmacists that were like, hey, my employer, probably isn't going to cover this. Is there any grant potential that helps me in the cost of this to help uptake? So we did partner on that using some of the opioid settlement funds. Facility policies, I think, is an important thing in external market forces. Every pharmacy is kind of make a determination of what their level of comfortability. Some pharmacies have actually implemented protocols. You're like, well, the law doesn't require you to implement a protocol. They've just determined that that's how they want to approach it, to standardize it across their organization. And that's okay. That's an external market force playing out. Liability insurance, as I talked about, we've worked with Pharmacists Mutual. We have not seen any increases, so that's kind of a false claim we hear from an opposition standpoint. We haven't had patient complaints and we haven't had provider complaints. And so there hasn't been new issues on the civil or criminal side. And then I would just say pharmacists, like self-restraint, professional ethics. Confidence continues to grow, but it's not a mandate. We've got early adopters like anything else. We've got people that are just now beginning to do this in Idaho. And we've got some people that they've decided not to implement this. And that's okay. It's an allowance. It's a permission. It's a pathway to go do it. It's not a mandate to do so. So I'll finish up. How will you advocate for pharmacist full practice authority going forward? At your tables, take the next 2 to 3 minutes and talk about what can you do in your community. In the conversation today, when we talked about offensive coalitions, as I've talked, what has come to your mind? How can you better engage with PSW on advocacy? How can you better engage at your current employment for advocacy? What are the things that you can do to get pharmacists to full practice authority in the state of Wisconsin? Let's use the next few minutes for that.
All right, folks. I'm back. You were expecting Tim. Shocker. It's not. It's me. So don't want to quell the discussions. I actually want to encourage those to continue here a little bit. I'm sure for some of you, for me in particular, this is a very exciting topic to think through and sort of chew on. And for others of you, this is probably really, really uncomfortable, right? This is something that pharmacists, we kind of like to know what we're supposed to do. There needs to be a right answer. But part of the intent of having this discussion here today is as we're pondering sort of where we go as a profession in the state of Wisconsin, I think it's important for us to consider the possibilities. So make sure you're taking some time at your tables now and later throughout the day. And if you run into board members or staff, if you are uncomfortable with this, like talk it out, like have some discussions, talk to your PSW leaders and to each other about what this means for you and how this fits in Wisconsin and what the possibilities could be or what your concerns are. It's okay to be uncomfortable. I think it's just very informative for us to be able to hear from you on how you're feeling about this, because I'm sure there are more than a few of you out there who are sort of like, if I don't have a rule book, I don't know what to do. And yet that sounds ridiculous, but I know sometimes I feel like that. So I get it. So, yep. And so so after that, thank you to Tim for chatting through that with us. It's very informative. All right. The most important thing, CE code. So the CE code is there for you. We're going to take a break here now, but before we break, I do have a couple of announcements for you. If you drop that thing, if you would like to purchase additional tickets for tonight's party at the Deer District, please do so at the registration booth before noon today. If you are already registered, or if you want to know if you're registered on your badge, if you have a basketball on there, that means that you have a registration for the party tonight. So make sure you bring your badge with you when you go. It's your ticket to get in. And so the Deer District itself is a short walk away from here. There is a map available for you in the app. And there will be a group in the Hyatt Regency lobby that will walk over at 6:20 if you want a group to walk with over there. Next, looking ahead for our schedule, at 11 a.m. today, please consider attending one of our exhibit theaters, Impact the When, Delay Onset of Stage 3 Type 1 Diabetes with Tzield, sponsored by Sanofi, in 102 DE, which is around that away. And following that program, you can grab your lunch at 11:45 and enjoy some networking time, check out posters, and listen to the latest in what's coming from our exhibitors. All right, we're now going to take a short break. We'll reconvene about 10 for the second general session. Thanks, everybody.